Well, thanks for spending some of your time here with me today. This is a really fun opportunity for me to give families some insight into sort of what aspects of science that we teach here in chemistry, in particular, the area of research that I'm involved with, which is measurement science. How do we make measurements that inform how people get answers about their health care? Interestingly, starts about 4 decades ago, 35, 36 years ago to be exact. And so for the parents in the room trying to normalize as to what 1987, 1988 looked like, this is what The Simpsons looked like. They just launched on the Tracy Ullman Show. One of the top shows was Cosby. Dirty Dancing has not aged as well. RoboCop has aged fantastic. And then, of course, Rick Astley's introduced us that we're no longer strangers to love together. But even though there's been a lot of change in pop culture, there hasn't really been a lot of change in how we receive health care. And this has really been something that has been striking to me in how rigid and inflexible it is in the United States, which is we as patients have to go everywhere to receive care. And it might be us as actual intact humans, or it might be us as samples. It might be sending samples somewhere, going somewhere to donate blood, that blood goes somewhere else. Sometimes blood gets lost in the mail, and that's really disappointing because then you have to go back to a phlebotomist and get more blood drawn, and all to let us wait to have an answer come back from us. And so sometimes we, as patients, need to go to some sort of primary care site. That could be our primary care physician, that could be a clinic. Usually those facilities don't have access to all the testing we'd like to have, all the instrumentation, and so our samples get sent out to some other lab. That information doesn't come back to us, that goes back to that clinic, goes back to that healthcare provider, who then gives information back to us. Sometimes what infrastructure they have access to isn't good enough, will get kicked up to a secondary lab or even a tertiary lab. And this is sort of the state of the United States healthcare system for good or bad. And whether your illness is chronic or whether it's acute, doesn't really matter as much. But we see an accumulation of time and frustration and confusion all the way across the board. And so where a lot of technology and innovators see ways to intervene in the system is in bringing access to technology directly to people, rather than having that person take time out of their day, take time off from work, find care, potentially lose salary a bit for their jobs in order to spend time on public transit to get down to a doctor's office, go to a convenience store, CVS, et cetera, buying tests, having tests nowadays actually shipped to them. And so this is really not only where I think a lot of interesting chemistry and technology is done, but I think also has the best possible way to change how healthcare is managed in this country. And we'll be focused on in the US as opposed to, it's really a global problem, but more from the perspective of the US. And so we think about starting off with chronic illness. This ends up being, if I introduce the idea of chronic illness and managing chronic illness, I think a lot of people's minds wander to situations where people either are unable to leave their homes or are coached to not leave their homes because they're potentially immunocompromised. I kind of think this is a little myopic view of when we think about chronic illness, because it ends up being much more pervasive than that. More than half of Americans live with a chronic illness. This includes hypertension, high blood pressure, arthritis, respiratory disease, cholesterol disorders, all the way down to diabetes. And this ends up being, when kind of overlooked, we think of managing chronic illness. There's just a lot of different kinds of chronic illness. Some of these need routine measurements made, particularly in the case of diabetes. You need a routine measurement made on the order of 4 to 6 times a day to check your blood sugar. Some of these other chronic illnesses, particularly things like hypertension, you need to make sure that your medication is dialed in at all times. And that becomes a really big burden, not for the healthcare system, but for you as the patient itself. But for diabetes, this ends up being not only a major acute problem in the United States and also globally, but it's one that's growing. And it's one that causes a lot of downstream challenges in terms of not only an individual's livelihood, but also all the way up to the economy. From the American Diabetes Association saying not only do nearly 1 in 30 Americans have diabetes, but that costs hundreds of billions of dollars a year in sort of lost economic growth due to people managing their illness. And this is beyond the United States. We're talking 400 million people or more worldwide live with diabetes, a lot in India and in Africa as well. And so this is a global problem. It's not just an American problem, and it's one that requires a solution that spans many different disciplines, from the basic biology to just what is diabetes, and from the perspective of what's happening inside of our bodies, how can we intervene with either nutrition or with medication, implants. There people are talking about building robotic pancreases in order to inject insulin for people that have type 1 diabetes. But a lot of it comes down to this imbalance of sugar, glucose. So for healthy people, healthy people have the ability to regulate the amount of glucose that's circulating in the bloodstream because your cells have insulin receptors that will detect insulin. For type 1 diabetes, your pancreas just can't secrete insulin, it's not making it. And so that leads to an abundance of glucose in the bloodstream. For type 2 diabetes, your pancreas is making insulin, but the cells that have receptors for insulin just aren't really good at detecting it, again leading to an increase of glucose in the bloodstream. And it's this sort of long-term challenge with managing sugar that leads to issues with damaging blood vessels, issues with eyes, nerves, kidneys, and then and beyond in the body. And so it's coming down to making a measurement that is going to allow us to improve people's lives. And from a person who likes to make measurements, from an analytical chemist perspective, this is a really hard problem, because the concentrations that we're looking at here between normal and where, for hypoglycemia, not enough blood sugar, need to intervene by eating food. Hyperglycemia, too much sugar, need to intervene with taking insulin. These concentrations are really, really close together. And so you need to have tests that are very specific just for glucose. You need to have tests that are very accurate. You don't want to have a measurement that is far off and you make the wrong decision on treating your health. And also something that's precise. You want it to be reproducible. You take one measurement, take 5 measurements, it all comes back the same. And so this ends up being a really, really big challenge historically, and thankfully one that we're starting to solve better and better as time goes by. But if we look back to history, one of the first at-home tests that's specific for glucose was 1957. It required urine. You dipped a test strip into urine and looked for a change in color. And it's sort of like litmus paper for testing pH. You sort of look at that, you match that color change. Hopefully you're not colorblind to the space these colors are actually being formed. And you make a determination of what your glucose level is. So good, we can test at home. It's specific, it's not invasive, and that's unlike a lot of tests that were rolled out previously up to this point. But what's bad is that the glucose concentration in your urine doesn't map at all to what's in blood. So this test actually has very little purpose. But the silver lining is the chemistry behind this test here. We can actually look to this very specific chemistry, this new enzyme called glucose oxidase, and use that in an entirely different way. And we're going to use that by turning the signal not into color, but into an electronic signal, an electrical signal. And so over the course of from the 50s, 60s, 70s into the 80s, different generations of electrodes have been developed in order to detect glucose using this enzyme. Some of them are really big. The first ones in the 60s were really, really big, required a few hundred microliters of blood. That doesn't sound like a lot, but for those of you that may give finger stick blood routinely, that's a ton of blood. Like that's basically cutting off the tip of your finger with a little guillotine and then trying to fill up a bucket. You can do it. You don't want to do it that often. And again, if the testing is supposed to be a few times a day, you're not going to have a good time after a while. And so what's interesting is that between the 60s and the mid-1980s, now we're back to 1987, now we have a device that's about the size of a pager. It's the same chemistry. It's the same reagents. It's the same system. Less blood because everything is being reduced down in size. So what's happening now is that we're taking advantage of the technological boom that happened in the 80s. Computers are getting smaller. Cell phones are a thing that are coming on board now. And it's the advance in the electronics, not the advance in the sensing, the advance in the chemistry, that allowed us to move from something that looked like this to what you can buy in the store. And so again, technology perspective, what has changed in the 35 years between this first at-home electronic glucose sensor to now is we're trying to use less blood. So now it's a 2 microliter, very, very small drop of blood, less painful. We're getting into more sort of like user-centric design around devices that are easier for people to use. They look slicker, curved bevels. You can store data, transfer data, ping to your phone. and potential for non-invasive modalities. People are developing mouth guards to detect glucose, contact lenses to detect glucose, earlobe clips in sweat, better specimens that are not requiring a finger stick at all, but will actually pair back to what's happening in your blood, unlike urine did. But no new chemistry, no new real technology, all repackaging of things that have been around for 35 years, but still having just a huge impact on people's lives. And so the next area, also happening around the same time, this is a blank slide. This is to let you know a little bit of a palate cleanser. COVID tests. So whether you're using the Abbott brand of the COVID test or any of the others that you can find in drugstores, they're all the same. There's nothing really unique about the devices that are inside. And I use the Abbott one because you can actually see this card open, and you actually can see the business end of the actual chemistry here. And then here it is in cartoon form. All of these devices, these lateral flow tests, look exactly the same. They're manufactured in exactly the same way. And fundamentally, this is why, for those of us that have taken several hundred of these at-home nasal swab COVID tests in the last 2 years, it's because this technology has been around since 1988. That's why they were first to market. That's why they were fastest to market. Massive infrastructure already exists to make these tests. It was swapping a little bit of chemistry here and a little bit of chemistry here, and that's what differentiates an HIV at-home test from an at-home pregnancy test to a COVID test to a malaria test in the field. The materials aren't different, the manufacturing processes aren't different. And so what I mean by conjugate, I have a lot of chemistry terminology here. This is basically what's causing the color to form, right? So there's going to be, and I'll show in the next slide. Ooh, cartoons. There's going to be chemistry stored in here that's actually recognizing something from the COVID virus. So that nucleocapsid antigen that you're getting out of your nose, it's going to bind to that, and on top of that binding event, there's going to be either a red signal because there's a really, really tiny gold nanoparticle, or a blue signal because there's a really, really tiny plastic sphere. And then all of that's going to migrate by flow automatically because you're dropping that dropper bottle at the end, and it's going to be captured at this test line. And so if you create this full sandwich, so there's something immobilized on our capture line, here's that COVID antigen, here's that conjugate that we've stored, we can start to accumulate color based on whether or not we have this antigen present or not. This is called a sandwich assay because we're sandwiching things together. Scientists like to use really clever terminology because we get bored. But also similar chemistry happens at the control, which is why you want to have 2 lines for positive and not just the 1 line for the test line. But again, this is ubiquitous, right? So just about any analyte that can be sandwiched can be detected in the exact same device. Pregnancy tests using blood or urine, HIV using blood or an oral fluid swab. You can pick these up at the drugstore. Drugs for recreational use by urine, malaria, and blood. These are things that you can't buy but are widely commercially available to testing agencies. Same thing with flu, another kind of swab that goes in the nose, and all the way down the list. And again, it's the exact same materials, the exact same manufacturing strategy. And just like our friend the glucose test meter, which was late 1980s, the very first at-home commercial pregnancy test was 1988. Really, really building off of old chemistry in the same way that the glucose meter was building off of old chemistry. But technology started to catch up to it. We could start to actually build devices that looked like this better due to advances that were happening sort of outside the sector of bioanalysis. And for those of you that have been able to use a pregnancy test, or again, of course, all of us with our COVID test, we're looking, in this case, maybe you want that second line. These lines can be really, really difficult to evaluate by eye, to the point where there are a lot of what's called false negatives, so where people don't think there's a line there, but there is, it's very faint. Or false positives. People think there's a line there, but there's really not a line there. They're kind of chasing shadows. I see a lot of people sort of looking at these test strips up against the light, out in bright light, under a fluorescent light, trying to figure out if there's a line there or not, using their cameras to figure things out. This is all very sort of older, easier technology, the innovation, so again, because there hasn't been innovation in the chemistry, and there hasn't been innovation in sort of the cartoon aspect of the device, innovation has to come from elsewhere. Let's make this easier for people to use. Let's make this way more user-friendly. And so rather than having a person look at that line under a lot of duress, am I COVID positive, am I pregnant, they decided to introduce little tiny electronic readers that will look at this color for you and spit out an answer that is very unequivocal. This smiley face. And I actually think this is also hard to interpret. You don't know if people actually want this to be a smiley face or not. So, so it gets, it's up to the user at that point. But so again, here we are, 35 years later, right? Using established chemistry, established technology, putting a new shine, a new spin, a new packaging on some old tech. And so on one end, you can talk about this from a technology perspective and say, why are we sort of mired in, why are we just stagnant? Why are we not developing new stuff? Well, new stuff is really expensive. New stuff is really risky. And the old stuff tends to work just fine. And so particularly in the case of a pandemic, the United States put billions of dollars towards developing new rapid COVID tests. This was the winner. This wasn't the winner because the new technology is not going to work. It's because the new technology would require massive infrastructure changes. And in a lot of cases, infrastructure didn't exist, as opposed to going to an Abbott or going to another company and just say, why don't we take this bucket of goop that you're striping and exchange it for this new bucket of goop, and now it's a brand new test. And that's why we're able to access hundreds of millions of tests, because we're not building new infrastructure, we're using something that already exists. And so upside is there's room for innovation. Hopefully your children or your children's friends are gonna be the ones that are looking at this stagnant technology and saying, why should I use something that was made 15 years before I was born? That hurts my soul when I teach them, but I think acknowledging that old is good, old is useful, old is very valuable, but there's still an opportunity for new. And so happy to take any questions.
So thank you. Give it a second here. There we go. Thank you, Charlie. We have time. We have about 15 minutes for questions, if anyone has any.
I wanted to make this more like an introduction to stuff, and then hopefully spend more time kind of chatting about this.
Excellent. And the mic would be helpful because we are recording this for later use.
Thank you. So what are you doing?
I'm giving a talk.
No. So, I mean, seriously,
Yeah, no.
what are your students doing? Because for instance, we use the Q test for our COVID tests. It's wildly expensive.
It's super expensive,
and it
right?
works.
It does work, but it
works beautifully, but it is not reproducible for the masses. What else is happening?
So at least in the COVID space, I think people are looking at the Q test, which is an at-home molecular test, right? So early in the pandemic, everyone said, has to be PCR, has to be PCR, has to be PCR. And I do not believe there will be such a thing as an at-home PCR test for a while. Those are just going to be too expensive to make and then broadly distribute. And so this Q test uses a different kind of assay where, so PCR is hot, cold, hot, cold, hot, cold, hot, cold, hot, cold, hot, cold, as rapidly as you possibly can in order to make more copies of DNA. And that requires an expensive instrument. So the one in our lab costs around 35 grand. You can shrink those down to maybe a few $100, but it's still too expensive for most people because that's just the instrument. Now you have all the actual test chemistry. The Q test is what's called isothermal. So you heat it up to one temperature, and there's no cycling back and forth. It's basically just a hot box. And that's how the chemistry works. That's easier to implement. That's easier to roll out. But the form factor of that test, there's just a lot of chemicals you have to use, and there's errors that come in to anytime you have a person touch it by themselves, you add error. The number of steps that person needs to perform in order to make that test work, you're compounding and propagating error. So it works fine, but it needs to be more bulletproof, I think, from the perspective of the user actually getting it to operate, like I said, reproducibly all the time. And also shrunk down so that way it's cheaper to manufacture and then send out to other people. But it's a good start.
So what's happening here at Tufts?
We were actually had a program sort of in the same area in 2020. It was a lot of fun, super high stress, as I'm sure you can imagine, trying to get people back to campus to do research on, at that time, an emerging pandemic, to try to build a new kind of test. And so we also went the isothermal approach because that's something that I know we can distill down really, really inexpensively. And we hit some similar roadblocks to the folks that Q did. And so we knew at that point, we made sort of the out-of-body decision that like, we aren't going to help right now. We're too far away to help. So what can we actually do? And so we ended up pivoting kind of really hard into more of the user experience part. Let's use that chemistry that works. Let's not try to invent new chemistry, but let's try to recognize that people need to use whatever technology is developed and make things smaller, easier to interpret, less ambiguous for an output. And so that's what we're moving towards now. And so it's, now we're 2 years past, we're very, very slow because the purpose of our research is to train students. It's not necessarily to develop products. Now, if that happens because we're super duper clever, then that's fantastic news because we want to be able to translate things that we're developing at Tufts and other institutions into the public sector. I think it's a really important part of doing scientific research is to have other people benefit from that, particularly research that's driven by public funds, that the public should benefit from that. It's just a slower process because it's like me and some students as opposed to like a company whose goal is to just put product out. Yeah, I'm teaching and doing service and all the other fun things that I'd like to do as part of this job. But I think what will come from this, hopefully in the next year, is a demonstration of something that hadn't been shown yet. We're not doing the next incremental step beyond what someone else has already done. We're trying to do a new thing. And that's slower and riskier, but taking on new risk is an excellent thing for students to do because they're gonna learn, and doing something brand new and struggling with it is one of the best ways for people to learn. And that's where big new things come up, is when you're trying to do something brand new. And if they fail, they learn, and everyone moves on to the next thing to try and to fail. If a company fails, the company goes under, so they don't try to do risky things. No risk, right? Things that have worked for 30 years, let's do that again and again and again. A lot of new stuff's gonna come out of universities because of the risk aspect, but that's why it's fun to be here.
Back here.
Hi, I'm a public health major at a different university. Is why I'm like,
Public
this
health.
is where I'm coming at this
we need
from.
you, yes.
Yeah. And so kind of the questions that I have about this are more about like reportable data from home testing. I noticed in the picture of the COVID test that you showed, the Abbott one, it had the little QR code where people can report that data, but it's not often used. People don't tend to report that data.
Only when traveling, because you have to.
Right.
Or you
And,
used to have to, yeah.
And you mentioned like an at-home HIV test or a flu test and things like that, like infectious disease.
Yes.
Do you find that being able to report that data from an at-home test is like an innovation that people are looking to further, or is that just like not something people are interested in terms of making it a more effective or helpful tool?
The idea of collecting data it's murky. Because I think there's a lot of value, particularly, let's take the COVID test for an example, right? If we were able to collect data from every single person that took any test, we'd be able to track actual prevalence, be able to track better, where to provide more resources, if we could figure out where the different communities that were impacted, let's say disproportionately to others. But then there's a privacy concern. There's no such thing as no data breach. And so thankfully, these are questions that are answered by people that are smarter than me. But I feel that there's a ton of value in responsibly collecting health data.
Okay.
Just wondering, if you go to the doctor once or twice a year, you get all the blood work done. Can that be done like this?
Someday, yeah. And I think that there's an opportunity for identifying what can't be done at home yet and building tools specifically for that. And kind of back to answer your question, I think that's where a lot of innovation is coming from, is saying like the market is driving towards more at-home testing, either because the person can take a meter, apply a small drop of blood, and get an array of answers. Or this idea of Everlywell and other companies where you can go and get a kit, put a little drop of blood in a card or swab your cheek and put it in a tube, send that off, and then get more information back kind of directly to your phone perhaps. And so there's a lot that's being driven to that area, is de-burdening, decluttering the healthcare infrastructure with things that might be just routine testing. Maybe it's done through telehealth to where your doctor or your primary care physician's watching you do the testing or helping you work through what the results are. But even in the last couple of years, I've had more, a higher touch with my electronic medical record than I have even with my primary care physician. I can keep track of data that I have through Fitbit, which is the simplest way to get real-time information on your health, or the iWatch, et cetera.
You like Fitbits?
I do, yeah. Fitbit was actually the thing that told me I had COVID for the first time, because I was sitting down and my Fitbit was telling me what a great job I was doing running. And I'm like, oh no, I'm surely watching a movie, what are you talking about? But my heart rate was like 135, just sitting down. And so that alerted me to something that was a problem. And also I thought I was hungover, but no, that alerted me that was the problem. And so I like responsible ways of keeping track of my health. It allows me to have more control, I think, over what I'm doing with my health.
Can you tell me everything a Fitbit does, or is it too much to describe?
Well, so the Fitbit will tell me heart rate. It can track due to, say, motion kind of sense. So heart rate by some light sensors that it has, that it's kind of tracking your blood flow in the skin directly underneath it. There's the same kind of sort of accelerometers that are in your phone that let your phone tell you what orientation the phone is in. And so it can differentiate a swimming motion from a running motion, from walking up and down the stairs, just based on sort of the position that it feels. And so you're seeing a lot like that in simple wearables. So the Samsung will have something, Apple will have something, Google always tries to come out with more sort of active feedback for people's health. They had an entire lab dedicated to smart contact lenses that got shut down.
Do you recommend your favorite Fitbit?
I like the Charge HR. I think it's very stylish. I have different bands to choose from because I'm vain. But also, I like the heart rate aspect of it. That's the most important thing for me. Charge HR, I think, yeah. I'm not paid by Fitbit, but I'd like to be. Yeah.
So my husband's Apple Watch told us that the lower chamber of his heart was no longer working. They're amazing.
They really can be. Although the new ones, they can't tell if you're in a car accident or on a roller coaster. So be careful with how sensitive they are.
Can I actually take that question one step further?
Sure.
So full disclosure, I'm a pediatrician, and one of the many things that I tell my patients all the time: Google is great for information; it's really bad at context. And my job is context.
Yeah.
And I have many colleagues who are cardiologists who are seeing a lot of patients for Apple Watch related concerns who are totally fine.
Yeah.
And so when you talk about our decentralized healthcare system, I think we have to find a way to create access.
Yes.
And with a lot of at-home testing, it's really important. I've spent 30 years of my life trying to figure out when not to do a test. And so how do we approach that? And I know this is beyond chemistry, but there are implications to lots of testing and worry and concern and extra strain on resources that are already limited, i.e. my time.
Right. And so this is a very internet age concern where now you have access to all this information, and what do you do with that, and how do you use that effectively? And so there's sort of like a joke of you Google your symptoms and WebMD tells you have cancer. It doesn't matter what the symptom is, WebMD will tell you have cancer, and that leads to a lot of anxiety. And so there is potentially a benefit to having people have more access to what's going on with their health. However, the other side of that coin is if people can't interpret that data responsibly on their own, it leads to other challenges, or then it leads to in the way we're trying to deburden the healthcare system by giving people more access to testing, you might increase a burden in the healthcare system because now you're being peppered with oh, well, my Fitbit says I didn't take a step, I took a step. Does that mean I have, polio? It's like, I don't know. I don't know what the answer to that is, right? Like, but so there needs to be, I think we're learning how to interact with data better and how we're able to take the agency that we have over testing or monitors. And the hope is that the outcome of it is a vastly improved healthcare infrastructure, both for patients and practitioners. We're not there yet. I don't know how long it'll take, but I think that's the goal of all of this.
So you talked about how things haven't evolved a lot since 1987, 88. Where do you see innovation coming from? Is it just more applications of this type of test, or do you see different type of testing coming? So just curious your perspectives on innovation.
Different kinds of testing for sure. It's kind of funny, so a quick step back. The vast majority of my career has been trying to impress upon people why at-home testing is so important. And then funding agencies going, no, it's not, clinics are great. Suddenly pandemic. And now it's like, of course, at-home testing is so important. And so we're really learning a lot of where there are some flaws in our system here and where people actually need testing. And so, the one area is the specter of being immunocompromised and what that actually means and how people are justly concerned about going out into the world that is treating the pandemic as being totally over and what that means for their health or the health of their loved ones. And so I think testing specifically in that area would give people like, yes, my white blood cell count is super low. I should not go out today. Or actually, my white blood cell count, my neutrophils are doing great. I feel like I actually could fight off an infection if I got one. I'm totally fine to go to this party. And so things like that would give people more control, more agency, I think would be very helpful. One of the sad things about an open-ended question like yours is Theranos really mucked it up. Because the concept of Theranos, which is bring that entire massive clinical laboratory infrastructure into a box at a CVS or Walgreens test center, brilliant. Not unique to them. People have been trying to do that for decades. The reason why no one's gotten it to work is because it's really, really hard. And they don't like to lie about it. Most people don't like to lie about it. But I think that you will move towards either in-home or near-home testing. But to the question made earlier, there's a downside to having a clinical chemistry or laboratory set up in everyone's home. I don't think the FDA would approve too many kinds of tests for diagnostic purposes that would be done outside of a laboratory environment. So thankfully, there's a regulatory body kind of keeping us in check in terms of what we can propose to do and where we can propose those tests to be used.
Last question here.
Am I to understand that there's an at-home test for the flu? You had flu up there.
They're in the same format. Those are not available for individual use, but you can go to your primary care or Minute Clinic and they'll swab your nose and run that test. So it's the exact same device. It's just not available for use in the home. And so that's part of like the regulatory oversight thing. There's a couple of things that you can justify this should be used in the home, and it can be used without risk to a person in the home. The flu test is just not one of them.
Professor Mace, thank you so much for being here, and thank you all.